Move to the next session. The first speaker, really, Bruno Casetta, really does not need any introduction since he's well known in the mass spec field. In the past and in the present, he contributed to develop and optimize many mass spec methods still used nowadays in many clinical labs all over the world. He's still working in the field, still active, some great passion and great scientific, but theoretical, but also practical knowledge of mass spec field. Some years ago, he moved to a new position in the private sector. He's now scientific director of the BSN, Biological Sales Network company in Castelleone, Cremona, north of Italy. Please, Bruno Casetta, thank you for being here. The stage is yours.
Thank you so much for this undeserved presentation. I know that the amino acid analysis has been covered by some previous presentation. This talk is more focused on the technical details of the various methodologies, and eventually on a novelty on work we are working in our lab. And since the title of this session is HPLC, I would like to start by highlighting a challenge of the normal chromatography. When we have two coeluting peaks which have a very low resolution, the good chromatographer should tell us that in this case, one way is to increase the capacity factor, which means that we have to elongate significantly the LC running for getting the appropriate resolution. Another way, and today it is practiced, is to choose a different column, a column which a different selectivity, in order to have the appropriate resolution of this peak. And the third option is to play on the efficiency. So what does it mean? To rely on the columns which have a very high number of plates, like the column with the small particle. And this is a way, today it is very well practiced. The problem is to have an LC equipment able to manage the high back pressure of this column, to manage the dead volumes involved by this approach, and as well to have a detection system fast enough not to distort the peaks. Now, speaking about the amino acids, and I am not the right people to tell you how important they are in the physiology, I would like to say that these kind of compounds are absolutely not friendly to the LC because they are polar, they are small molecules, and on top of that, they don't have any chromophore sites. So this is why in the 1958, some researchers in UK, Stein and Moore, developed a strategy which is the ion exchange chromatography. Of course, it was conceived at that time with the tools available at that time. And this approach is still valid today, of course, through compacted instrument like this one. And still today, it is regarded as a gold reference. As it has been already mentioned this afternoon, one of the drawbacks is the length of the chromatographic run. Could be 2-3 hours, depending how critical are some separation. And in addition to that, the recognition of each analyte is done only by the retention time, since the non-specificity of this approach. And of course, in the case we have co-eluting substances, maybe not amino acid, of course, they can create a problem. And on top of that, there are in any way some critical separation, like the one which are listed here, the argininosuccinic acid, the alloisoleucine, the tryptophan, and the homocitrulline, for example. On top of that, we have to consider that the amino acids have concentration ranges very different each one. And in particular, I would like to mention the phenylalanine, because phenylalanine is one of the markers of the phenylketonuria disorder, which triggered the attention of Dr. Kutry, who was personally, unfortunately, interested in this amino acid, who wanted to develop something which was not lengthy like the amino analyzer approach. And because that, he tried to devise an assay, which is a bacterial inhibition assay, where in fact the quantitative appreciation is really a semi-quantitative, like you see here. The white circle is more or less indicating the concentration. In the 90s, when the LCMS came out and started to be adopted by several hospitals in a second way and university and so on, some researchers from North Carolina, and I would like to mention Millington and Chase, had an idea to use mass spectrometry to compete with the Guthrie assay. So what they did, they found a way, without any chromatographic separation, to be able to read either the amino acid and the acyl-carnitine profile. And this is now practiced by almost all the world for the neonatal screening because it is very fast, quite simple, and it doesn't involve any chromatography. It doesn't involve any chromatography because the specificity is guaranteed by the tandem mass spectrometer, as you see here. And I don't want to repeat the concept. The concept is that for getting a signal, the ion or the substance we are interested to must pass two pass filters. One is centered on the molecular weight of the analyte we are interested to, and the second mass filter is tuned on a fragment, after a fragmentation which is occurring in this third quadrupole. This is the way to do, and this is the way we are, an example of what we are getting, looking at the amino acid analysis with the neonatal screening approach. We see, of course, that each analyte here is somehow accompanied by an internal standard, and we will speak about it later. Of course, the number of explored amino acids is quite limited, but enough for the neonatal screening purpose. And as I mentioned, it is quite fast. Now, the first approach as devised by Millington and Chase was using the derivatization with the butyl alcohol just to make the instrument more sensitive. Today, this is not more the case because the high sensitivity instruments allow to run this assay without any derivatization. Anyway, if desired, we have always the possibility to implement a chromatographic separation like it is shown here, a very old one. And on top of that, today, as it has been already mentioned before, we have the possibility to extend the number of the explored amino acid. Today, we can go up to 40, 48, 50 amino acid. The only question is that If we do it without derivatization, we must be very, very cautious, because the fragmentation process, the reading with mass spectrometry is somehow affected by a phenomenon which is called ion suppression effect, where indeed the ionization can be affected by some either chemical or physical disturbances on the ion spray itself. This is why sometimes, or most of the time, we have a reduction or an increase of the ionization yield. And as we say, the most weak part of a mass spectrometer is not anymore here, but it is here. And for addressing this issue, now we have we must consider the need of the internal standard. And the best way for having the right internal standard is to have the same analyte isotopically labeled. Why this happens? It happens because the element coming from the column can bring some other matrix components we don't see because the high specificity of this process, or can be the bleeding of the column itself. So anything else can influence the rate and the yield of this process. This is an important issue, and this is the reason why sometimes we see in a chromatographic run like here the appearance of two peaks. One is the analyte we are interested to, and the other one is the amino acid isotopically labeled. And so the signal, each signal must be normalized with the internal standard. Another way for getting the same result, but in a more elegant way, is to use a legacy coming from the proteomic side, where instead of having the analyte isotopically labeled, we use a derivatization reagent itself isotopically labeled. In this way, we have the possibility to derivatize, in our case, the amino acid with one version of the reagent and have it prepared, and at some time we add the same mixture of the amino acid, this time labeled, derivatized with the labeled reagent. After we mix, and we get a signal like before, where we have the coeluting the two peaks, giving the same possibility as before. This is what we are getting in this case. Each amino acid is accompanied by its internal standard. We see here the arginine confronted with the internal standard. Now, what we think to be the beauty of this new approach is that the number of the amino acid we can explore with this approach is unlimited, because now it is not anymore the case to search and to buy the specific amino acid isotopically labeled, because any new amino acid we would like to include in a panel we are interested to can be done. This is what we are getting by running excuse me, a serum sample. And interestingly is that with this approach, the peaks are very clean and very well designed with no tailing. This is important, with no tailing. So chromatographically speaking, the derivatization, at least with the derivatization reagent we are experimenting in this moment, is very effective even on the chromatographic side. The beauty is as well that we have the possibility to distinguish without any problem the so-called isobaric amino acid like the famous sarcosine between the beta-alanine and the alanine, not speaking about the triplet, the famous triplet of the isoleucine, and so on, the methylhistidine, the 1-methylhistidine and the 3-methylhistidine, for example. So this is, excuse me, this is one of the features. The other feature concerning the performances on the quantitation, this is the famous glutamine, and we will speak about it later on. This is the tryptophan, another amino acid subject to the oxidation. And an important point for us we discovered by chance is the fact that in order to address, the stability of the amino acid, we made some experiments, and it came out that, in effect, the amino acid the analysis of the serum amino acid should be done as soon as possible after the collection of the specimen. Here are, here are some the rationale behind this change of the concentration, like the bacterial contamination, which supposedly increase the alanine, glycine, proline, the storage and the temperature and time, with the loss of glutamine, which is converted to the glutamic acid. Of course, we can even have some hemolysis if we stay with the blood, the whole blood. Now, what we found, and I repeat, by chance, when we were looking for addressing this question, is that when the sample is prepared and the derivatization approach we are proposing is very, very simple, the extract is very, very stable over the time. As you see here for the glutamine, here is a span of 8 months, but now we are even more than that, the arginine and the ornithine and so on. So with that, we can now make an attempt in comparing the available technologies, the today available technologies. So the first one is, of course, the gold standard, which is still referred as the gold standard. The LCMS, let's say, with the traditional approach, with no derivatization as most of the people like, and this new approach, which I call isotopolog derivatization, where in fact we are labeling not anymore the analyte, but we are labeling the reagent. Now, if we look at the first point of comparison, of course, a criticism can be that in front of the fast sample preparation of these two techniques, where in fact we do simple protein precipitation with either the sulfosalicylic acid or an organic solvent, here the addition, we have to add the two reagents. And keep in mind that 5 and 10 minutes is just for being on the safe, but the reaction is at room temperature and very, very fast with the reagent we are using. The second point is that, as expected, now we don't have anymore the running time. Here we are more or less for both at the level of 20 minutes. Of course, the chromatography here, since we are still staying with the native amino acid, the separation is a little bit more critical, and the chromatographic behavior is slightly worse than this one, where, in fact, thanks to the derivatization, we have the analytes which are getting less hydrophilic. The next point is that, which can be very important for many laboratories, is that For the classical amino acid analysis, we need an indicating instrument. Meanwhile, with the two-order approach, we are using the, let's say, the common LC-MS instrumentation. The third point is the disposal of how to manage the waste. Keep in mind that here we have the classical LC environment where the eluents are accumulating after the eluents and the ninidrin we are using for the derivatization. The post-column derivatization must be somehow wasted. Here with the LC-MS, it is a marginal point, but it is the case to underline it is that no issue because anything which is entering in the mass spectrometer is exhausted through in a gaseous form. So we don't have any liquid to manage. And of course, we don't have the ninidrin. The third point is the sensitivity. Here we have the sensitivity, which is appropriate for the job in running the amino acids, so no issue that it is appropriate. Here we have relatively good sensitivity as long as we have a high-level instrument, but the sensitivity remains very heterogeneous, which means that the glutamine has a high sensitivity and the glutamic acid a low sensitivity. The reason is depending on the, on the molecule itself. Here, because this derivatization, the sensitivity is more homogeneous. The next point is that, as I mentioned before, the UV signal is something which is very reliable, no doubt about that. Here we have, as I told you before, the ion suppression, which is present. Here we still have it present, but at less extent. And anyway, for both the cases, we have the correction with the internal standard. The next point is the fact that on the pure chromatographic side, of course, as I mentioned before, here it is challenged by some critical separation. Here we can have sometimes, because the analytes are at the low molecular weight, they can be affected by some isobaric impurities, and as we have seen before, with this approach, the baseline is very, very, very clean. And as I mentioned before, here the number of the explored amino acid must be fixed. There is no way to add any more. Here we can add them some more amino acid as long as we have the internal standard, which means to have the amino acid isotopically labeled. Here, as I mentioned before, there is no limit because the reagent is doing the derivatization, is doing the labeling. Last but not the least, and this is something which surprised myself as well at the beginning when we started to develop, is that meanwhile in these two cases where we are managing or handling the native amino acid, we must be careful in doing the analysis close to the specimen collection. Otherwise, we have the instability affecting several amino acids. Here, we have experienced that the good stability of this new derivatization form, we can collect the sample, do the derivatization, and after left the extract 4 months in the fridge or in the autosampler as we have done, and be able to read it afterwards. And with that, I would like to thank you very much.
So thank you, Bruno, for the overview. And this new analytical method is very promising. One question? Okay.
Yes, thank you for the talk. We did evaluate a kit some years ago from SciEx.
The iTrack.
The iTrack, and one of the things that
I
we
know
noticed...
because I was the developer.
Okay, so you might appreciate this question. We try to apply that kit as an evaluation to actual pathological samples. And one of the things that we found in certain conditions that the stoichiometry was quite poor. There were far too many reactive components. The stoichiometry, so the derivatization reagents were often underperforming because we couldn't derivatize the totality of everything that was going to be looked at in the amino acid profile. So I think, for example, tyrosinemia type 1, we added in 8-fold excess of the reagent and waited, I believe, an hour longer than we were waiting for. And every time we did this experiment, increasing the concentration, we kept on recovering more tyrosine. I believe we had a case that came through with hyperprolinemia type 2, where we did not achieve sufficient derivatization of the proline because it's just not the preferred moiety to be derivatized. Could you speak to how this isotopologic approach has changed from the original ITRAC and what you've done to sort of correct for the stoichiometry of secondary amines and the abundance, particularly in metabolic crisis, of some of the derivatization targets?
Okay, as if I understand well what you are complaining is that by first, I know very well the ITRAC. In fact, I was inspired by the ITRAC with. Of course, the reagent is different. And keep in mind that even with the ITRAC at that time, we didn't emphasize so much the fact that it is like any derivatization reagent, they are very sensitive to humidity, okay? Now, with the ITRAC you have used, you remember, it was delivered at in a very small volume, okay? So, of course, here we are not facing this problem because we are speaking about humans volumes to be handled, okay? So, the reagent is different, okay? And in the case of the ITRAC, the only comment I can say, because I have worked a lot of that, is the humidity. Okay, the humidity of the derivatization, of the derivatizing reagent which was dissolved in acetonitrile. So even here could be, but could be that, of course, here the reagent is in acetonitrile as well. It doesn't look to be very sensitive to the humidity, but it is a good practice for any reagent we use for the derivatization, and usually it is an esterification somehow, okay, acting on the amino group. It is a good idea to take care of the humidity. So, which means once you take out from the fridge or from the freezer the reagent, to leave it for half an hour on the bench for reaching the room temperature before opening the vial.
Fully appreciate it. We did control those experiments as best we could, but I still have questions around the stoichiometric relationship between the number of derivatization reagents versus, say, a normal plasma profile for amino acids, and that same stoichiometric relationship to a pathological plasma amino acid profile. Because if you get metabolic crisis, you tend to increase the number of amines across the board. I mean, just ammonia itself will go well up. Have you increased the number of molecules or the concentration of your reagents in this instance to account for the differences between a normal plasma profile and a pathological one? Understood. Thank you.
Honestly speaking, the environment where the people who are developing is slightly different from
Bruno, the microphone.
Sorry. I would like to say that sometimes the environment where the researchers are working, like mine, is a little bit different from the environment of. When I say environment, I say the fact that you are stressed to be fast and so on, and it is slightly different. But honestly speaking, we have seen in Europe people who have used it. It doesn't. You know, the problem could be that at that time we tried to propose that the internal standard was also acting as for the quantitation. Okay. I know that somebody refused to consider that. But as far as I remember, the people were, the criticism, honestly speaking, the criticism was on the price. And this is the big mistake of at that time. I can say it because I am not anymore an employee of SciEx, okay, because I am retired. So I feel free to tell you that.
And nothing personal about SciEx, it was just an observation. And the second part of my question was the secondary amines were more difficult to derivatize. Have you corrected that with this new mechanism of derivatization? Yeah. So we'll get a higher recovery of proline and other secondary amines in the amino acid profile. Thank you.
Okay. Thank you very much, Bruno.
Okay, before we continue with the next speaker, on behalf of the organizers, I would like to thank Anna Maltabe from Anachem company that made this session possible. And now we are going to the next speaker, which is going to speak about a subject which is very, very new to our society and to Greece, and is also has to do about the true measurement of GFR using, let's say, reference method. And this is something that the EFLM, the European Federation of Laboratory Medicine, is promoting that at least in each European country should be a lab that be able to measure GFR with iohexol using as an external administrative agent in order to have in certain clinical situations that the true measurement of GFR is important, and the calculated methods that calculate estimate GFR are not sufficient. So the next speaker, Fabiola Carrara, is going to speak about this subject.
Good evening. Thank you, the organizer of this meeting, for inviting me. I'm very proud to be here to discuss about different glomerular filtration rate methods available for determine with iohexol plasma clearance to determine through glomerular filtration rate. Glomerular filtration rate is the best overall index to kidney function. Each kidney is okay. Each kidney is constituted of about 1 million of filtering unit called nephron. Each nephron includes a filter called glomerulus and a tubule. So glomerulus filter the blood, and tubule concentrate the product of filtration. So in the tubule, there is a reabsorption of electrolyte and other substances, and the final product of the kidney, the filtration of the kidney, is the urine. So with the glomerular filtration rate is the amount of blood filtering in 1 minute from the kidney. Here we can see the normal range for GFR. In green, normal condition, and in red, the requirement of dialysis and kidney transplantation. To measure GFR, we need a marker. An ideal marker of glomerular filtration rate should be constantly product, fully filtered by the glomerulus without secretion or reabsorption by renal tubules, should be safe and without extrarenal clearance, and the method for quantification of the concentration of the marker, it should be simple, easy to perform, and provide results accurate and robust. Moreover, the relationship between the concentration of the marker and the measured GFR should be linear and inverse. To measure GFR, we can administer exogenous substances such as iohexol, iopamide, iopamidol, and so on, or it can be estimated after the use of these endogenous compounds such as serum creatinine or serum cystatin C. However, these endogenous compounds are affected by this kind of error, such as extrarenal elimination, tubular reabsorption or secretion, generation, and assay error. While for measure GFR, this non-determinant kind of error, there isn't. However, to perform measure GFR, this procedure requires multiple blood sampling, and only specialized center can perform this procedure. For this reason, in clinical practice, several equations based on endogenous creatinine or cystatin C level have been developed to estimate GFR. In our work published on Nature Reviews Nephrology, we document that the relationship between measured GFR and serum creatinine concentration is not linear, but is curvilinear. So, for a concentration of serum creatinine on 1.5, we can obtain a wide range of measured GFR for a single value of serum creatinine. And the same occurs when we measure serum cystatin C. Moreover, estimate GFR incorrectly stage the chronic kidney disease in 30 to 60% of the patients. So, the estimate GFR were unpredictable and comparable across equations based on different endogenous markers. This is because when the authors that develop the equation use a criteria for the validation of their formula, the mean of percentage of patients at least at 80% with an error of 30%. But this error is too wide. For instance, how many patients with hypertension would be diagnosed as normotensive if we use a sphygmomanometer with this kind of error? In this picture, it's more clear. If we measure the height of Obama presidents, we can, with a 30% error, we can obtain the height of Peter Dinklage, the winner of the Golden Globe, or the height of the tallest living man in the world. So, with this picture, it's clear that 30% error is unacceptable to evaluate the performance of an equation. Moreover, several guidelines recommendations suggest that when to measure kidney function, when GFR will impact treatment decision, and all nephrologists should have at least one method using urinary or plasma clearance of exogenous marker, such as iohexol. Moreover, European medicine agencies recommend to measure GFR for drug dosing, such as chemotherapeutic drugs. However, in different laboratories, people use different protocols to calculate GFR. Different protocol, different sampling time collection, different exogenous markers. So recently, a consensus paper of the European Kidney Function Consortium established, first of all, iohexol as a marker of choice to measure GFR in Europe, since it's available several markers. Okay, so iohexol is the marker of choice. Plasma clearance instead of renal clearance, because with plasma clearance, we avoid to collect urine and to have other source of error, such as the empty bladder. And they establish the fitting model, the pharmacokinetic profile that describes better the decay of plasma concentration, and the analytical method to quantify the iohexol, because we have several methods such as ELISA, electrophoresis capillary, and other methods. So this is the best method for quantification of the compound. Okay, let's now have a good look about the procedure. On the morning of the renal evaluation, we inject 5 milliliters of iohexol intravenously after a bolus injection, and a multiple blood sampling after injection of the marker are collected. This to describe the pharmacokinetic profile, that is, here the fast component, which is the distribution phase of the compound. Here we have the equilibrium, and this is the slow component, the elimination phase of the compound. The pharmacokinetic profile is a two-pool system with all this blood sampling. However, we agree that this procedure requires so much blood sampling, so much blood, a high number of blood raw. So we simplify the procedure, avoid to collect in this phase, and we collect the sample only at the equilibrium and only in the elimination phase. After we correct the area under the curve of for this point where the blood draw is not performed, with a broken Mortensen formula, is available in literature, and the calculation of GFR is the dose injected of the marker, and the ratio between the dose and the area under the curve of the plasma decay of the filtration marker. We validated internally the procedure, and here we can see a typical chromatogram that we obtain in HPLC UV, and iohexol elute in about 4 minutes. And we also externally validated the procedure with several laboratories, in particular with mass spectrometry, with Hospital of Chicago. And we measure in parallel, and we are totally blind. And here you can see an excellent correlation between mass spectrometry and HPLC UV. And this data have the advantages that HPLC UV is available in almost the clinical chemistry laboratories. We evaluated also the precision of the procedure, but not of the method, but the overall reproducibility of the procedure. After determination of plasma clearance of iohexol in 24 patients, measured on 3 different occasions, and we obtain, this is the coefficient of variation, and this is the mean. The overall reproducibility is very, very good. In 25 years of experience and more than 50,000 GFR determination in different conditions, so in diabetic kidney disease, in end-stage renal disease, on peritoneal dialysis, and in kidney transplant reception and living kidney donor, we observe that the prevalence of iohexol-related complication is negligible, with only 0.014%, and we observe only one event. However, this event is not serious because after administration of the marker, this is a diabetic patient, develop itching, flushing, and urticaria. But this event was resolved after injection of methylprednisolone, so without sequela. So we validated 2 protocols for measure GFR according to estimated GFR. For patients with estimate GFR higher than 30 milliliter, we collect 5 blood draw at 120 up to 4 hours, so every 30 minutes, while for patients with estimated GFR less than 40, we must extended the procedure from 4 hours to 8 hours because due to the renal impairment, iohexol accumulated in the blood. So the slope becomes flatter, and to define the slope of this curve, we need to elongate the procedure. This is the reason why we have 2 different protocols. However, recently, researchers developed a population pharmacokinetic model to determine glomerular filtration rate using limited sampling within 5 hours, even for patients with impaired renal function. They collect 2 samples before and 2 samples in the elimination phase. Very few number of blood draw instead of us. So we try their performance, taking to the advantages that we have the full pharmacokinetic profile, because they collect before. Sorry. We collect only in the elimination phase, and they collect here. So I recalculated with our data available in 30 clearance study to compare population pharmacokinetic model with our reference 2-compartment model with a full kinetic profile. And this is the phase A study. And after, in phase B study, we compare our reference 8-hour 1-compartment model, and we abbreviated the procedure up to 5 hours. Here we can see the results, the mountain plot that show a percentiles for each rank difference between the reference method and pharmacokinetic model. Here we can see that in blue, the peaks deviated to the left. So these data indicate a large overestimation of estimated GFR with a population pharmacokinetic model. Moreover, there is a wide range of error, and this error is comparable to that obtained with the two commonly used formula to estimate GFR based on serum creatinine. So, why we must inject an exogenous compound if we have the same performance? It's clear that it's important to collect to describe the pharmacokinetic profile in a proper way. In phase B study, we compare our reference method, 8 hour, with save hour, 6 and 5 hour. So we plot the reference against mean percent error, and if two methods are in agreement, the mean percent error cluster near to 0. So this is okay, but we can observe that the error increases in parallel with the abbreviation of the procedure. In particular, at 5 hours, we have some patients with very unreliable results. So we conclude that we can simplify the procedure up to 6 hours. Now, we can say an example how the GFR measurement applies in the clinical settings. This is an example in a genetic disease, autosomal dominant polycystic kidney disease. This disease is caused by mutation in these genes, PKD1 and PKD2, that codify for a protein polycystin. And this disease is associated with a development of renal cyst, and this patient develop renal impairment after few years. This disease is caused by the mutation of these genes, and PKD1 is most common respect PKD2. And this mutation lead to renal insufficiency, so to need of dialysis and kidney transplantation, on average 20 years earlier. So, we perform a longitudinal cohort study in more than 100 AD-PKD patients, where GFR was centrally measured at baseline and a follow-up. We measure GFR with iohexol plasma clearance, and our aim is to evaluate the relationship between measured GFR and estimated baseline, and during 1 year of follow-up. Here we can see that at baseline, GFR estimated by the two formulas with CKD formula and DRD formula, creatinine-based formula, significantly correlates with measured GFR. This is the correlation coefficient. However, we know that correlation coefficient is a poor statistical parameter to evaluate agreement between two methods. In fact, as we can observe, for CKD overestimate measure GFR, significantly overestimate measure GFR. MDRD underestimate measure GFR. And the percentage of patients with a mean percent error within 10% that we consider virtually identical to measure GFR is about 50%. So if we flip a coin, we have the same probability, 50%, to detect this condition. So again, it's clear that the equations are not so good. Here we can see Balland-Altman plot, and we can see that the performance of the two equations is poor at any degree of renal function. Here there is overestimate values and underestimate values. Moreover, we observe no correlation between measure and estimate GFR change at 1 year. This data is particularly important because we aim to assess an efficacy of a pharmacological treatment. We must detect the progression of the disease. So with this data, it's clear that formula to estimate GFR fail to detect the progression of the kidney disease. Now I show you an example, not in a genetic disease, but in a multifactorial, very common disease, such as type 2 diabetes. In type 2 diabetes, patients in the early stage of the disease develop a condition called glomerular hyperfiltration, which is a supraphysiological values of measured GFR. Glomerular hyperfiltration is not protective, but is a risk factor to reduce GFR. So it's very important to detect this condition in the early stage of the disease. And again, we observe that also in this population, there is a poor correlation between formula to estimate GFR and measure GFR, and moreover, all formula underestimate measure GFR, but the error is not casual, but is systematic. With an increase of measure GFR, the formula underestimate the true value. Moreover, in this patient, we take hyperfiltering patient with measured GFR. We have 90 patients, and we can see that, again, all formula fail, underestimate the number of hyperfiltering patients, and in particular, we observe that CKD formula detect any patient, no patient were detected with this formula, which is the most commonly used formula to estimate GFR. So we can conclude that shorter GFR protocol surely offer advantages and allow more frequent monitoring of renal function. However, oversimplify clearance procedure do not perform adequately and are not recommended. Moreover, in peculiar subject, I show you this condition, but I have a long list of other conditions such as malnutrition, cirrhotic patient, and other conditions. And in this peculiar subject, the use of the formula should be limited to routine clinical practice. and when necessary, for instance, to determine the efficacy of new drugs in slowing the loss of renal function, GFR determination should be performed using a method such as standardized iohexol plasma clearance. Thank you for your attention.
Thanks a lot for the beautiful presentation. Before we go to questions, I would like to make 2 notes. One, it is that from all the methods that up to now have been developed to measure GFR, from chromium, DTA, clearance, and all the other methods, the older methods, this is the only one that when we measure GFR with using the use of iohexol, there is an external quality assessment scheme that all labs can participate. This is the Equalis, I think.
Yes.
Yes.
Equalis.
And the second is that when you showed the slide with the equations, different equations, you had also the Cockcroft gold. There are also, this is not an equation that estimates GFR. This equation was created around 1970-something, 76, I think, and it was to estimate creatinine clearance in blood. So many clinicians in Greece, they're still using this, especially in ICU units. So I think that people of us that work in the laboratories should go and tell them to stop using this equation. It's not an equation that they can estimate GFR anymore. So if you have any questions for Fabiana.
I have a here, Fabiola. A speculative question starting from your conclusions. So there is no doubt that measure GFR is essential and outperforms estimate GFR in a specific subset of patients and in specific settings. And there is no doubt that iohexol displays advantages with respect to other methods. But recently, a survey involving 15, 20 laboratories across Europe and a couple of laboratories in North America was published, showing huge variability among these labs applying iohexol, both for pre-analytical, but also analytical and post-analytical conditions, such as restriction from tobacco use or hydration, which are known to potentially affect the measured GFR. So my speculative question for you is, can we move now towards harmonization, or it's too early, we are not ready, or we are ready to chase for harmonization in the use of iohexol?
Okay, I agree with you, because true GFR does not exist, because also measured GFR can be affected by this kind of error. However, recently we published a consensus paper to establish, to reduce the error of the quantification of the iohexol. So your question is, also measured GFR is affected by bias,
Yeah.
because it does not exist. I agree with you, but as I show you in here, published on Kidney International, this paper describes exactly the protocol to adopt sampling time, to standardize and have harmonization in Europe, because several laboratories some lab use a single point. For me,
So there are already
no
a
sense.
big effort to move towards standardization, or at least harmonization.
It is Natalie Ebert and other people are working in a working group in EFLM in order to harmonize the measurement and the pre-analytical and analytical and post-analytical phases of measuring GFR with iohexol. So it is a progress on this, and they will, yeah.
Moreover, iohexol, instead of other exogenous marker, show a very excellent stability. So it's ideal for multi-center studies, because after different cycle of freeze and thaw, we document an excellent stability of the molecules. So we suggest to use this compound instead of other as euthalamate that has also tubular secretion, and iohexol is the marker of choice in Europe. So if we move obviously in clinical practice is enough serum creatinine, but for peculiar patient, it's very important, for instance, to define the living kidney donor before the transplantation, to detect if the donor is a potential available donor.
Thank you.
Okay.
And also, it is important that you see the balance there. It is required to measure, to weight the syringe that contains the iohexol before administration and after that, in order to.
Yes, it's
to
important to
exactly
balance the syringe. It's important balance the ceilings, but our nurse not measure the syringe because it's graduated, and if a nurse is well trained, the most important of this pre-analytical is the nurse, because we can do nothing if the nurse is not able to perform the procedure. Okay. Because sometimes we observe contamination, because iohexol is viscous. If we inject in an arm, the bolus injection in one arm, and we recommend to take the blood in the other arm. If you have a well-trained nurse, sometimes after washing with a saline solution and remove the volume of the saline solution, we can take from the same arms. But the most important is the nurse. Okay.
Okay.
Thank you.
Yeah, you can go. Okay, we finished with this session, and now we have a very special guest from the United States. It is Dr. Ravinder Singh, which is director of the endocrinology lab in Mayo Clinic, and has developed a lot of mass spectrometric methods in order to measure various endocrine molecules. So, please, Dr. Ravinder.
Thank you again for inviting, and thank you to all of you for staying at the last minute. I know there is a wine waiting out there, and so I'm going to take you through a journey that when I started into the endocrine lab, that I was working with the endocrinologist, and the disease example we're going to take is Cushing. So the medical textbook will say if the patient looks like a moon and has a lot of fat development, they may have Cushing's. But unfortunately, there are a lot of obesity in the rest of the world coming up, but this disease is very rare. So Cushing is very rare. It can also happen in females also. It is very rare, and the physicians have a lot of challenges to find which is the right patient, because surgery is invasive. So some of the symptoms are that they do develop purple stria here, and so pre-test probability was emphasized that we need to do this testing only in the right population. Physicians should have a lot of clinical doubts Only then if you apply the test, then you have a chance of having a good positive predictive value for these situations. So this is what I'm highlighting, is that people in these 3 indications can also present with the pseudo-Cushing-like symptoms as well. But if we are talking about, so the physiology is very simple. Cushing's are 2 types. Either the tumor is making ACTH, or there is a tumor at the adrenal gland which is making cortisol. We are going to talk today about the steroids methods, how do we measurement. So we are not going to talk as much about, even though most of the Cushing's is because of the tumor at the pituitary level. So normally there is a feedback inhibition. In the morning, you have a very high cortisol because you have a very long day coming up ahead, but at night it is at low. But in people with the Cushing's, this diurnal variation is gone. In those people, the amount of cortisol in the morning and in the evening is high. And I think a lot of work has been done in metabolomics, but again, I think we need to still work on adrenal-based metabolomics. So this is a cross-section of the adrenal gland outer cortex, which is responsible for glucocorticoids, mineralocorticoids, and sex steroids. And there's another type of tumor, which is called pheochromocytoma, which is due to the catecholamines, dopamine, epinephrine, and norepinephrine. So because this is a rare disease and we have cortisol test in multiple metrics here, urine-free cortisol, I think you all know this is a 24-hour urine specimen, which is very difficult to collect. Plasma requires, blood draw, and then plasma-free cortisol is another test, and midnight plasma cortisol has also become available in the last decade, and now we have salivary cortisol. And the question always comes is, do we need all of these tests? I don't think I will be able to discuss that topic today, but all these tests have been developed to improve the clinical outcome so that we can provide a better solution to the physicians. And we can collect a sample in the urine as a blood draw and the saliva. So each one of these is not a perfect specimen. There are issues here of not full collection here. Saliva has a lot of pre-contaminations, like your bleeding can affect it. And then again, because of the stress, these levels can go up as well. So the steroid field is not new. We have been using these assays for a long time. Very first assay was colorimetric assay, that you take a urine, hydrolyze, and then add a coloring reagent, and then you read by the spectrophotometric. But as people were trying to screen more patients and screen early on, then these assays were good to detect changes when they were 10-fold, 20-fold, 30-fold, and you could see that the patient has a disease. But then we switched from colorimetric assays to the paper chromatographic assays. But then in mid-80s, we went from simple chromatography to the gas chromatography with the flame ionization detection. But this is really where there is a big revolution happened when Dr. Rosenjello discovered how to make antibodies against insulin, and she was given a Nobel Prize. Then we started using antibodies for all these steroids, and all the big companies started making these assays. But very soon it was realized that these assays do have cross-reactivities with the steroids, so then at low concentrations, a lot of interferences were recognized. As marathon is going on outside, and you guys are the founder of the Olympics here, so today the amino acids are not used in confirming the doping. So that method is still isotopic dilution, gas chromatography, mass spec, and GCMS, because this is the gold standard. So these amino acids are good, practical, low cost, but they do not meet the standard of the care. So any legal issues, whether it is a doping or employment issues, you would have to use the GCMS assay. So the challenge we get is that most of these steroids are hydrophobic. So they circulate in our body as free, then they bound to the binding protein, This binding protein for cortisol is called cortisol binding pro, but these steroids do also have affinity to bind albumin as well. So now there is a concept that in testosterone field that if you look at free testosterone plus testosterone bound, this bioavailable may be a better biomarker than the free, because free is the only one which goes to the receptor. But this binding being weak, so at least for cortisol, we still look for only total cortisol. There are some situations where we do dialysis to detect, but this is historical here where all the steroids need to get excreted, because otherwise if their half-life stays longer, then they will always be bioactive. But in order for them to get excreted, they do get conjugated to glucuronides and sulfates. And these were our old way of measuring when we did not have very good sensitive, but now we have very sensitive method that we can really look for the real cortisol method. This is just an example here highlighting that when you are using one antibody, then this is the kind of the inverse response you get. And your linear part of the curve is also very limited. So at a low concentration, your signal change is very small. So there's a very high precision up here. And then there is a very high, high CV, sorry. And then there's a high CV also here. So the assays are only good for this very limited linear range, which can be 1, maximum 2 logs here. But for the sandwich assays like ACTH and SHBGs, I think these sandwich assays have done very magic, and these automated platforms are very reliable most of the time. But we cannot use 2 antibodies. That's the message here. For small molecular weight like amino acids and others, you can only use 1 antibody. Then 1 antibody brings the problems along with it. Ideally, because we don't have a lot of workforce, not a lot of people are interested, or LCMS is not that common. Everybody will like their lab to put the sample on the track, get the results in 30 minutes, but it's a necessity that we need to provide not only rapid results, but also the accurate results as well. This is the College of American Pathologists proficiency data, and then you also have similar EQAs here. For plasma now, the situation is not as bad. The Abbott instrument is being used by 190 labs. The mean is 13.26, and for vitros, the mean is 16. Ideally, there is going to be 1 accurate number. We don't know what is accurate between 13 and 16 here. So for urine cortisol, a lot of labs are not using the amino acids anymore, because the doctors even know it, that amino acids in urine will cross-react with the urine metabolites of cortisol and cortisone. So most of the labs have switched to the other assays. So now there are basically 3 different approaches. So you can start, even if you extract the amino urine and then run on antibody assays, your reference range is 24 to 108. But if you extract it and then, so this is extracted, then amino acid, this is extracted, then HPLC, UV assay, but then you can see its reference range is 5 to 55, because antibody is also cross-reacting with the metabolites. And we will figure out what those metabolites are. And then because of the laborious method, then now the field used to use LCMS, but we know that LCMS-MS is by orders of magnitude better than simple LCMS. So like every lab, you saw multiple speakers at this conference that you need, so mass spec is expensive, but you can then multiplex by adding multiple HPLCs, but everything is not FDA controlled. So you're buying this from one manufacturer, pumps from the other manufacturer, this is from the other manufacturer, then solvents and columns for all. You're trying to put a recipe together, and this is where our FDA and US has challenged us that we need to put all this together and get the approvals. But hopefully you don't have that problem here. So this is the table you get from the amino acid manufacturer, and as you can see it here, antibody not only has a cross-reactivity for the cortisol-cortisone metabolites, but this is interesting here that antibody does have a cross-reactivity. If some patient is taking prednisolone or prednisone or 6-methylprednisone, basically all the signal you're getting by the immunoassay is because of the drug, not because of the cortisol. And that problem does not happen with the our LCMS. And these are, the more you go deeper and deeper, more you find those, what are the various compounds which can cross-react with the antibodies. So this is just an example here. If you take a sample and then amino acid result, doctor doesn't like, you run by HPLC, most of the samples will be okay. But this was the area here where, cortisol and cortisone, but on this sample, it was still very complicated. So our technologists were not very happy in calling this, result. But if you take the same patient, and 20 years back, we, used to use single LC MS. So this is single LC-MS. Now the runtime, these peaks are coming around 10, 11 minutes. But if you go back, this runtime was much longer here. So even a single LC-MS was able to reduce the runtime, but now we know that with the LC-MS-MS, we can get results every 2 minutes. So we have made a lot of progress. Our sensitivity is equally good. We can provide a good specificity. We can separate cortisol, cortisone. Of course, mass spec cannot resolve the isobaric compounds that came up in the last discussion with Bruno's talk, amino acids. And steroids do have that problems, also some of the steroids, but then you rely upon your chromatography. But for cortisol, we were very successful here. I think I'm going to pass on this slide that you all are expert how the triple quad has helped us in reducing the interferences. Our HPLCs don't have to be that long now because, for example, here, these two compounds have the same molecular weight, but one compound has a fragment of 163, and one compound has, like this is cortisone, this is prednisone, but if we are only interested in monitoring 163, then this will not be seen by our signal. So again, you get a very good Q1 spectrum, but then this is the key here. Your the Cullinan cell gives you this ion, then rapidly these two signals are being put together. So you are getting not a compound specificity based upon just simple M+1, but you're also getting specificity based upon the daughter ion, and most of the fragments are known. And in this case, cortisol does fragment here, and then we know that this is coming from. And this was also touched upon in Brian's talk. A lot of help is needed. The lower you go, because these kind of signals are very easy, like he was saying yesterday, but then this signal could, smoothing and all that kind of thing. So that's the challenge. So LCMS has opened another can of worms, to be very frank. We thought amino acids were bad, but these small things, when you go deeper and deeper in about LCMS assays, we have a lot of issues as well, which are costing us time and money. That's the point here. So just to remind it here that we are separating cortisol and cortisone here. And if you look at the correlation between the amino acids, so this is extracted. So both are extracted. So amino acid results, so mass spec results are only 35%. So the real truth, cortisol, is only 35%. Rest of the 65% is something else, which is being picked up by the antibodies. That would have been okay if this relationship was consistent. If the R square was 1.0, then we could have understood that for every 1 molecule of cortisol, there are 2 or 3 molecules of the interference or the metabolite. But it's unpredictable that which patients have what kind of metabolites. So if you would have to pick one assay over the other for urine-free cortisol, I think the answer is we don't need a lot of debate on that, that if we go bad, then this assay should not be used at all. This was a real-life example. So one of the doctors gave us a patient here. If you notice here, the amino acid cortisol was 38.1, LC-UV was 1.3, LC-MS didn't see anything, but this was all because this patient was taking this drug, which sometimes physicians know, sometimes they don't. Because the signal was present, the antibody in this assay was cross-reacting with this one, and 38 signal was coming from 130 microgram of And these are the other patients here. Methylprednisolone, when it was present at this concentrations, the cortisol value was high here. Even LC-UV ran into the problem here when we know that real cortisol was here. The good news here is that antibodies do not cross-react with dexamethasone and betamethasone. I think the fluorocortisone ran into some problem later on in the literature. But so these are the kind of the studies where either the manufacturers becomes transparent to the labs or labs, mass spec experts work with these amino acid analyzers so that we know what are the negatives. But if you use two extraction plus chromatographic, then this is the kind of the correlation and the slope you expect. So this is also 11% higher results, which is probably that our calibrators were not aligned between the two methods. So ideally, this should be 1.0 and this should be 0.99. And most of these dots probably still should be on the line if the methods are totally transparent, but that's a fantasy that we will never see in clinical world. So if everything goes well, so this is a patient who had Cushing's, and if you do the good lab test, her surgery was done, and then this patient returns back the way she used to look like. So these days, doctors are asking, bring your Facebooks, social media books, then they can, if this person changes into this person within 6 months, then chances of having Cushing's are very high. But if this patient doesn't get the cure, this patient can die within 5 to 10 years. And there's a lot of books published where patients are frustrated that doctors don't believe them they have anything. So, but this is where the more we work with the clinicians and more we work with the public, we can use. So at Mayo, we have one Nobel Prize. Here is Dr. Kendall, who had been working with the bovine adrenal glands in 1960. Then he extracted cortisone, and Dr. Hench gave it to the patients because some of these patients, you remove the adrenal gland, so they need something back. So that cortisone is given as a drug. But this was discovered in 1960, but later on this patent was shared with Merck, and then they commercialized it. So that is just a privilege that Mayo had. So this was the compound E, so cortisone is also called compound E, but then this gets converted into the body by 11-beta-HSD type 1 to the compound. So this is cortisol, this is cortisone, and this is kind of converting back and forth. And we know that the normally mineralocorticoid receptors should have only action of the aldosterone, but cortisol gets converted to cortisone, so it doesn't cause as much hypertension in normal people. So I'm going to pass on. This is so now the pharmaceutical industry has come up with other synthetic steroids. So for example here, now we have prednisone. There is just showing that 4 milligrams, I think this is a little bit off, so 25 milligram of the cortisone is equivalent to of these lower doses here. So these compounds are much better used, but now we are talking about 1960 to 2024 here. So this is another case here which will help you in understanding what is the value of the LC-MS test is. So 19-year-old girl was admitted to the hospital somewhere in Europe with severe hypertension. She had hypokalemia and metabolic alkalosis, but she became normotensive as soon as she was admitted into the hospital. You want to try give the answer, one of you guys, what this patient may have? Normally, this kind of presentation will say this patient may have primary aldosteronism. So when the potassium is low, alkali is high, but this patient doesn't have a tumor because as soon as she got admitted to the hospital, she got cured. So for the sake of time, because you guys are waiting for the wine, so let me finish the story here. So this was her blood pressure, that her blood pressure was high, but as soon as she got admitted in the hospital, her blood pressure came normal. So, but if you look at her cortisol, so this ratio was also changing when she got admitted. When she got normal, her ratio had changed. So she was taking a licorice, and I have heard, maybe Brian can tell me, that American licorice is not as good as is European licorice. So this particular girl was using licorice, so that licorice is strong. And how does licorice affect this? Is that licorice contains one of these compounds, and this is where licorice inhibits that enzyme. So this particular patient was unable to inactivate cortisol into cortisone. And then this cortisol can also act on the mineralocorticoid receptor and cause the blood pressure to be high. So as soon as that her belongings were taken away, they were put in the closet, she didn't have access to the licorice, she became normalized. But normally we don't use this ratio normally, but it can be helpful in those situations. So I'm going to move on. This is another situation here that if patient is lacking, so we have investigators or some pharmaceutical companies, they want to make an inhibitor of this enzyme here. The benefit will be because this compound causes obesity and hypertension. This compound keeps your bioactive cortisol inactivate. So if you could keep all of your hypercortisol into this form, you will not have the side effects of the cortisol. So we are, waiting for that drug to get approved. And this is a nature experiment. So this is a Cushing's patient, but she did not have the symptoms. So this patient had the pituitary making ACTH and body making high cortisol, but her body was converting back into cortisol, so she didn't have any symptoms. So her body, nature had given her that mutation not to convert back into cortisol. So there used to be a test where we used to look for these kind of patients, where we used to look for metabolites, the ratio of these metabolites, but we don't need to look at for the metabolites anymore because we have a very good sensitive method for cortisol, cortisone, which can help. Actually, Dr. Paul Stewart's work we were talking about has published a lot on this because there are genetic mutations also which can help in sorting it out. There is a syndrome called upper end mineralocorticoid excess or cortisone reductase deficiency. All right, so I do have another case here. This is a young girl, and she comes to the Mayo Clinic, and then she has all the symptoms of Cushing's, and doctor does the imaging, MRI, all the steroid tests we do, but we could not find anything in her. And so she has all the Cushing symptoms, but then doctor is getting kind of frustrated that lab testing may not be right or something like that. But then we tested her, that is she taking one of these steroids, and then we have developed this method where we are looking for all these are exogenous steroids now. So we do have a method where we look for if somebody is taking these are medicines. And you will be happy or surprised to know this particular girl has been using Canalog or triaminoxidase 6 months back as an injection into the knees. And when we tested her urine, we were able to see only traces of that steroid present. We could have easily missed because these steroids are hydrophobic. They sit into the body, into the fat. But doctor was very happy to see at least this is causing, she just waited another 6 months, and this girl's symptoms were resolved. So this was touched yesterday that we do have mass spec, steroids which can be used. So upper girl here is born to the mother where she has a male genitalia, but in the next pregnancy, mother was treated with a dexamethasone then the normal baby was born. So amino acids versus, so these patients who have a 21 hydroxylase deficiencies, we use 17-hydroxyprogesterone as a surrogate biomarker. But if you want to improve the specificity, you can add androstenedione and then divide it by cortisol in order to decrease the false positives. And normally we just report the test which is ordered by the doctor, but our technology has shown now we can run hundreds of metabolites quantitatively, but clinically we were able to come up with an assay where we could look for all those genetic abnormalities, because there are abnormalities where patients can have 3 beta SDH deficiencies, 11 hydroxylase deficiencies. So any deficiencies can be figured out based upon the ratio of the precursor and the metabolite. And these are the retention times. So in normal patients, you have a lot of cortisol, very low androstenedione and OPG, but in an affected patient, your cortisol will be low, andro will be high. And now there is a new biomarker, which is also called 21-deoxycortisol, which is also turning out to be as good as OHPG or maybe better in some situations. I would like to finish with this one is that now we have been challenged that can we use our mass spec technology to help with the adrenal tumors. Most of the adrenal tumors are not cancerous. They are like Cushing's, primary aldo, or FEO. Their symptoms and hyperactivity can be dangerous, but they are not cancerous. But now we are going to apply that. Can we use a steroid profile to distinguish patients? Like a small percent of the Cushing's can be cancerous. So the radiology, normally is very good, looking at the size and the Hounsfield units. But, this is a slide which was long when I started my career, where I said the CT picture is good, is worth thousands, but our lab tests are worth millions. But now I'm changing that. This radiology is becoming, not only they're looking at the size, they're looking at the washouts. So our competition is becoming smaller and smaller. So the radiology is also probably becoming worth millions as well. So now doctors are finding a lot of adrenal incidentalomas these days. Anybody who goes with a stomach ache, some kind of abdominal ache, or for even chest pain, they cover this area, then they find small tumors. But because we don't know whether they will kill somebody or not, then until the lab test finds out, is that a tumor functional or not, that tumor should not be taken out. But it does create that panic between the physician and the patient. Oh, I found something. No, we have to do something. But this is an area where 2 to 11 persons are malignant, so definitely we need to find them. So the question is, can our mass spec tool help them out? So the survival of this tumor is very bad, that at stage 4, only less than 10 people can survive. So this work was published by Dr. Adol Ribka in 2011 with Dr. Paul Stewart, where they applied to the steroid metabolomics and detecting, but I think when they did this study, they only had access to the GCMS, so they did not have as much experience with the LCMS-MS or with the plasma steroids. So they ended up going with the urine metabolites then versus the serum active steroid. So the hypothesis there, why we need this expensive profiler test, because currently we are having these patients who have symptoms, which is a stage 2 or stage 3, they're hormonally active, then we perform the test to decide. But now we are talking about a lot of patients who don't have any symptoms, but imaging find the adrenal incidentaloma, and we know that a lot of them are going to be benign, but we will be doing unnecessary biopsies and unnecessary surgeries for them. So at the moment, the practice is that they repeat radiology every, depending upon the age and the other symptoms, then they may do the PET scan, but all this is coming with a cost as well as some radiations and other side effects as well. Then they can decide surgery or not. But if we have a good mass spec method with a profile, then we can help them out. The hypothesis here is that metabolomics of the normal adrenal gland will be much different than the normal Cushing's adrenal adenoma or primary aldosteronism versus the cortical. If you remember, adrenal gland has all different enzymatic pathways. So we are hoping that there will be different metabolites which can help us out. So this is the way the serum, pathway works. Again, taking the example of the 21-hydroxylase here. So the hypothesis is there that as tumor is becoming cancerous, the tumor cells will not mature all the way. Some tumor cells will stop here, so they may not have these compounds. They may not have these compounds. They may only have 11-deoxycortisol because the cells are dividing too fast and too quickly. They are not fully maturing. So 11-deoxycortisol is one of the possible biomarkers for malignancy, but instead of just looking at this, now the method is looking for all of them to improve the sensitivity and specificity of the diagnosis. Dr. Wipka's and Paul Stewart's work was not looking for the serum steroids because they didn't have that LCMS, and they went back to the old way we used to hydrolyze the urine, and this is the metabolite of 11-deoxycortisol. So tetrahydrodeoxycortisol is the metabolite, and accordingly, pregnant trialone and pregnant diol are the metabolites. But I would not recommend anybody to use those urine steroids, especially the hydrolysis one, because they are very complicated. But because this is a rare disease, we wanted to reproduce their work, so we implemented this work. And this is their published data where they determine the reference ranges by just using the GCMS method. Now we have LCMS method. Also, the reference ranges in the similar ballpark range. And they also had shown that LCMS, it was single LCMS, but we have gone actually not with the LCMS-MS, we have gone with a high resolution because we knew the more steroids you look for, the more interferences. So we have gone with the Orbitrap at Mayo because my colleague, Dr. Graber, really wanted to make sure that we don't have any interferences. So this is the way that in adrenal cortical carcinoma patients, the value will be much, much higher for these 7 or 8 analytes. So this test has 90% sensitivity and specificity. And this test is available now in US also at our labs as well. So the high resolution, I think not many people talked in this conference here. When we deal with a simple triple quadrupole, you're looking for all these masses when you know that the steroid molecular weight is 239.1581, but all these black line, all those signals are being added. So this is where, and this signal from the matrix also becomes part of the same peak. And that is the reason, ion suppressions and the specificities, even with the triple quad, some of these fragmentations may disappear, but high resolution is difficult to beat. And this is another example here that when you have a high resolution, your specificity goes very high. So assay methodology is very simple. We are using 150 microliters of the urine. Then we are hydrolyzing. But this is an old recipe here, so now you can do all these assays in serum and plasma and create the same profile, and it has almost the same diagnostic performance here. But if you have, this is the way the Thermo software looks like. You review all those peaks and all the ratio software. But, this is what causes the cost. You have to run 26 calibration curves. You are confirming, based upon the guidelines Brian presented, that you have to make sure that you have qualitative and confirmatories, and then you have the good internal standards, and that does increase the cost. But I think in a situation like this, LCMS-MS definitely is the winner here. So with this assay, what we are hoping is that based upon the steroid metabolomics, it will be able to help those patients. If they are not ASCC, they should not be requiring biopsy. They should go directly to the surgery, and our clinicians are very happy with this because they're experts. They have all the images, but this is their final confirmation of that tumor, which looks like in the radiology may or may not be active, but our steroid metabolomics is going to help making a decision if this patient, so number of surgeries will go down, which is good for the patient care. Thank you very much for your attention.
Are there any questions for Dr. Ravinder Singh?
Thank you for the excellent presentation. Do steroid metabolomics differentiate between pseudo-Cushing and Cushing's, which can be dilemma in the clinical practice, or they're not different?
Distinguish Cushing's and?
Pseudo-Cushing.
Oh, pseudo-Cushing's, not yet. I think we are, cyclic Cushing's and pseudo-Cushing's. No, we are not there yet.
They're still difficult to differentiate.
Right,
Yeah.
right. But we do have one investigator, she is looking for cyclic Cushing's. So now she is taking hair as a specimen. And then, because some patients have Cushing's, but they don't show the symptoms, or it's a cyclic Cushing's. So now she collects the hair, and then she monitors like 1st centimeter, 2nd centimeter, 3rd centimeter to confirm whether this patient has that. So we are just fixing the problems with the immunoassay at the moment.
Yeah.
We have not gone deep, but maybe you will do that.
Yeah, thank you.
Any other question? If
Thank
not-
you, everyone. Let's enjoy.
Okay, thank you very much. And also, I would like to thank also Matteo with the marathon president here. And I would like to ask the president of our society and the chairman of the scientific program committee to just give us the welcome.
Okay. We arrived at the end of this day also. Thank you for staying here. Normally I should welcome you, but in reality, the majority of the scientific program has passed until now. But anyway, thank you all of you on behalf of the Greek Society for coming here, for supporting our Congress. Thank you all presenters for their excellent presentation and the job has done. Supporting also the new methodology of mass spectrometry. And thank you also our sponsors that made this Congress possible. I should say that these peripheral small congresses are as important as the major congresses, but are defavorizing because they are using languages that are not very common all around the world. But now with the possibility of AI, we can have easily simultaneous translation, and most of the presenters speaking also good English, so there are not any more barriers in order to attend these small congresses and to present very recent research. So thank you again. And now there is outside the welcome cocktail.
Well, I don't have anything else to add, so thank you all, primarily you who attended and participated, and all the speakers and presenters. And we'll have another exciting day tomorrow on this symposium. Okay. Thank you very much, and we welcome you at the cocktail.